Hi, good day. Thank you for joining us in this high bleeding risk webinar. My name is Azeem Latib. I'm from Montefiore Hospital, New York. I'm joined by two friends and great colleagues, Flavio Ribichini from Verona in Italy, and Petrov from Sofia in Bulgaria. Thank you both for joining us on this important webinar. And really what we want to do today is raise awareness about a specific group of patients we often forget about in the cath lab. That's patients who had a high bleeding risk. I'm often surprised how these patients, they're there every day, and often they get ignored and we forget about them until they come back with a bleeding event, and then we're faced with the issues of how do we manage their antiplatelet therapy. So the way we'd like to do today is we'll start out by giving you a little bit of the data about high bleeding risk patients, and in particular about the Onyx 1 stent and the clinical data around the Onyx 1 stent in this group of patients. And then we'd like to share with you two clinical cases that will help really highlight some of the decision making that we all go through every day in the cath lab. In particular, when it comes to how we treat these patients and how we make decisions about what are the right therapies, what is the right drug-eluting stent. So let me start and get right into it, if that's okay with you, Ivo, Flavio, and we can make the most of our time. So who's the patient at high bleeding risk? There are really a number of factors that you should be thinking about. It could be age, and commonly in most of the studies we talk about an age more than 75. There are comorbidities that increase the risk of bleeding, such as renal disease, liver disease, active cancer. There are also blood dyscrasias, such as anemia, patients with low platelet counts, patients who've had strokes or intracranial hemorrhage in the past, or those who do already have a bleeding history, such as a bleeding diathesis or prior bleeding or transfusion, or they may be on drugs that increase the risk of bleeding, such as oral anticoagulants, nonsteroidals, and steroids. And another important group that we often forget about is the patient who needs to have planned surgery, whether that be elective or urgent surgery, who now has a stent, or who has coronary artery disease that needs to be treated. So these are the patients we think about. There is now also a high bleeding risk consortium that really has tried to create uniform definitions so that we can easily identify who this group of patients are and identify them when we see them in our cath labs. There have been a number of studies that have really tried to target this group of patients and give us, as interventional cardiologists, some sense of what can we do to lower the risk of bleeding. And in general, we define these trials as trials where the risk of BARC 3 or 5 bleeding is more than 4% in 1 year. And depending on which trial you look at, you see some of the trials really had very high risks of bleeding, some a little less, some are still awaiting completion. But also, if you look at the variables we spoke about as to what makes a patient a high bleeding risk patient, they're very variable between the trials. That there's an inconsistency of definition. Now, all of us here on this program have been involved in the Onyx 1 global program, and I was fortunate enough to be one of the PIs. And I wanted to share some of that data because I think that data is really relevant to this group of patients. This was a global study. It was a prospective, multi-center, single-blind, randomized trial in the kind of patients with those criteria I mentioned, high bleeding risk patients, who were randomized to either a Resolute stent or a BioFreedom stent. And remember, the BioFreedom stent used to be the only stent really approved for 1 month of DAPT in Europe. 2,000 patients were randomized in 84 global sites with 1 month of DAPT. So at 1 month, all the aspirin or the Plavix could be dropped. In patients with oral anticoagulation, if they were taking triple therapy, you would drop a single antiplatelet agent. But we also did allow for patients to have oral anticoagulation and a single antiplatelet agent. You see here the endpoints, but really the primary endpoint was a safety endpoint looking at cardiac death, MI, or stent thrombosis at 1 year. This truly was a study that looked at short-term DAPT. You see that 92% of patients were on single antiplatelet agents at 2 months and 88% at 1 year. So we did make sure patients stopped one of the antiplatelet agents. And it was pretty well divided between what they stopped or what they continued. So just over half continued aspirin versus under half that continued with the P2Y12 inhibitor. Just one slide just to remind you of the clinical endpoints. This study has published in the New England Journal of Medicine earlier this year. But when we looked at the primary endpoint, cardiac death, MI, stent thrombosis, really no difference. The rate of myocardial infarction, also no difference. It may seem quite high when you look at it and say, oh my goodness, there's a high rate of MI in the two groups. I want you to notice that all of this is peri-procedural MI. So you see the curves go up immediately at the time of the procedure and then remain fairly flat afterwards. Cardiac death, also no difference, and no significant difference in stent thrombosis, even though there was a numerical difference. So this study really changed a lot. It gave us confidence that we could treat these patients with a drug-eluting stent, and we could treat them effectively, with a very modern drug-eluting stent with good deliverability, and we could stop their DAPT in 1 month. As a result of the study, the Resolute Onyx is now, the first DES to be CE marked for 1 month of DAPT in high bleeding risk patients, including patients who are unable to tolerate long-term DAPT. Now, that took care of Europe. I'm now working in the United States, where I was surprised when I moved to the United States that in these high bleeding risk patients, bare metal stents were still being used. Remember, the BioFreedom stents not approved in the United States. And so when I got here, I was very surprised. So I was glad that Medtronic continued this study of Onyx 1, this program, and did a single arm study dedicated to the United States, where, again, high bleeding risk patients, same criteria as the Onyx 1 global study, but now single arm, because what you would do was compare the data to a performance criteria. Again, looking at similar endpoints, cardiac death, MI, but assessing them only in patients who were really 1 month clear. So we had no events up to 1 month. Those patients then you stopped one of the antiplatelet agents and continued for 12 months follow-up. And if you look at the primary endpoint, extremely low, 7%. The performance goal was 9.7%. So really the study met its performance goal. The data was presented by Ajay Kirtane at ACC. Again, low rates of stent thrombosis, 0.7% rate of stent thrombosis. This is a high bleeding risk population, so 4% rate of bleeding. And MI rates, 4.8%, which are very similar to the Onyx 1 Global, because in this study, we excluded peri-procedural MI. Remember, we were looking at events between 1 and 12 months. So it really was MI during follow-up. As a result of the study, the Resolute stent is now also has increased and approved, has their label in the United States changed for this expanded indication where you're allowed to now give 1 month of DAPT in high bleeding risk patients. I wanted to make a couple of comments about this study and how relevant this study is to our clinical practice. Both the Onyx 1 Global and Onyx 1 Clear did not have any angiographic inclusion criteria. There was no criteria about how many stents you could implant. So it really was an all-comers type study. You could do left main stenting, you could do long stenting, multi-vessel stenting. There was no exclusion criteria for this. And as a result, you see that 80% of patients had B2C lesions, and the stent length per patient was not short, 38 millimeters. So these were not 12 millimeter stents. A lot of calcified lesions as well. And also a lot of complex patients, half ACS. There was no exclusion for NSTEMI or STEMI. You could include both of them. A third had AF and a third diabetes. And a lot of, 1.6 high bleeding risk criteria in the study. The study has also given us a lot of information about a lot of subgroups that will help us understand better how to treat our patients. One of those subgroups is the ACS subgroup. So if you look at these two stents, Resolute and BioFreedom, in a patient with acute coronary syndrome would take only 1 month of DAPT. Once again, you look at the MI rates, pretty low, 5.7% rate of MI for Onyx versus 9.6 for Biotrium. Obviously, this is a subgroup analysis, but these are promising and reassuring data. Risk of stent thrombosis, 1% in both groups. So again, reassuring. The only other subgroup analysis I thought is really relevant to our daily practice is we also did a sub-analysis done by David Ganzari looking at complex versus non-complex lesions. Complex being defined, as most of you will agree, lots of lesions, long stents, bifurcations, calcified lesions needing atherectomy or left main or CTOs. And there were 400 patients, 1/4, who were actually defined as complex. So quite a few. And when you look at complex in yellow versus non-complex, again, of course, we're not surprised to see a slightly higher rate of MI, more complex patients, and a slightly higher rate of target lesion failure. But once you start adjusting for all the other complexity, this is not significant. But I think it's, again, reassuring when you look at stent thrombosis rates and cardiac death rates that stopping DAPT in a patient where you need to stop it, who went a complex procedure, was safe in this group of patients who underwent complex stenting. So I think what you're going to see in the next two cases, and I'm going to pass it on to my esteemed colleagues now, is that we're really at a stage where we need to really individualize for each patient. I don't think Onyx 1 is telling us to stop DAPT at 1 month in all our patients, but it's giving us more data so that we can really tailor our approach to the patient and try and balance really the risks of ischemia versus the risk of bleeding. And I think the best way to show you how we do that is to look at a couple of clinical cases. So thank you for your attention. And I'm going to pass it over to Flavio.
Thank you. Thank you very much, Azeem. Thank you for this introduction that is absolutely helpful and necessary to follow with our webinar today. Just to be sure, you hear me well?
Yes, we do.
So I can continue because it's not good talking alone, It's not
I agree.
We have prepared a couple of cases that are the best way to go straight forward to the point. And so I will start with the first, which is a coronary case I did several years ago. It's a woman, it's 65 years old. It's a very fragile person with very low body weight. And as you know, this is just by itself a risk factor for bleeding. After that, one of the worst, I think, it's the need for real oral anticoagulation because of a mechanical valve in aortic position. She has a resistant arterial hypertension with the need of many drugs, and it's a heavy smoker despite all these health problems. She has advanced chronic kidney disease. She has only one kidney, and of course, as a sum of all these factors, she had a chronic multifactorial anemia. She also had an autoimmune disease, it's rheumatoid arthritis, and long-lasting therapy with chronic corticosteroids. She has also diverticulosis and gastric ulcers. So believe me, it's a real case. It seems prepared on purpose to put you in a frightened position, but it's a real woman and she's still doing well. So that's the good part of the story. Let's go to the next slide. This is one of the recommended scores to calculate the bleeding risk in a patient undergoing interventions. And as you can see, hypertension, abnormal liver or renal function is one of the key issues in this score. The previous occurrence of a stroke, previous occurrence of major bleeding, and not the need of having a prolonged NIR, like in this case. Age above 65 is by itself a bleeding risk. And of course, the use of drugs, which can be alcohol, but also needed drugs like medications predisposing to bleeding, like in the case of this patient is the corticosteroid therapy. So when we calculate the Hals bleed score of this patient, it's come to be 6. And anything which is over 3 is considered to be high risk. If we go to the next slide, we will see Why it is 6? Because she has all the risk factors that I had mentioned before, with the only exception of a previous stroke. The next slide shows you that it's not only the need for anticoagulation, like in the case of this patient who is taking oral anticoagulation because of a mechanical valve, but in the case the patient is in need for primary or emergency PCI in an acute coronary syndrome, we have to calculate also the risk related to the use of other antithrombotic therapies like the antiplatelet. In the precise DAPT, which is the score recommended by the European guidelines, the use of oral anticoagulation is not even considered. If we see the next slide, we see that the precise DAPT score for this patient comes to be 40. And as you can see, anything when it's above 25 is considered to be high risk. So this lady has an extremely high risk, which goes above 25, even though this score does not consider the need for oral anticoagulation. So it's certainly much higher than 40. Next slide. This is her ACG at the hospital presentation with acute chest pain and with a hypertensive peak. As you see, it's not an ST elevation MI, but there is an ACG which is difficult to interpret. There is LV hypertrophy for sure, there is some tachycardia, and there are ST segment changes that are difficult to interpret. But with the typical chest pain and a rise on the troponin, the patient was considered to be ischemic. And so she underwent urgent coronary catheterization because her Gray score was really very high, much more than 140. And this is what we found at the coronary angiogram in the next slide. The catheterization was performed through the radial artery as it is recommended in general, but in particular in patients with high bleeding risk. And as you can see, there is an intermediate lesion at the proximal part of a dominant right coronary artery. I remember this is a very minute, small woman, and so the arteries look smaller, but actually these are the size corresponding to her BSA. Next one is the left coronary system, where you can see again a diffuse disease with some focal spots creating in the proximal parts of the LAD certainly a severe stenosis and some moderate intermediate lesions in the mid segment. Next one. Okay, I'll make a point here. I think I have convinced you that this lady is certainly a high bleeding risk. She has an acute coronary syndrome and she has these two vessels disease. It's difficult to determine which is exactly the culprit lesion on the basis of the ACG, but we have certainly a diffuse coronary disease. So I'd like to hear your opinion.
Ivo, I'll let you go first.
Yeah, it's a very interesting and complex case. It's really quite difficult to make the right decision in such a situation. You mentioned already she's a tiny lady, fragile. It's probably better in this situation, high bleeding risk, fragile lady. It's probably better to conclude, or at least to try to guess which is the most important lesion. In our case, I wouldn't go to a very complex, very long procedure to pursue the complete revascularization. I would go probably for the LAD. And definitely this long lesion, it looks to me definitely is very significant. And I don't know if what you think about the FFR guided PCI. Probably it's a good option to put a wire there, FFR wire, to take a look at the RCA. and probably if not significant, to limit the intervention with the LAD. What is your opinion?
Yeah, Eva, I would tend to agree with you. I think, using physiology to make your decisions, so we don't put unnecessary stents, are important. I mean, I certainly think this is a patient I would offer PCI to, rather than, repeat open heart surgery. So for that, I would have taken that off the plate. And I also think she needs, I don't think medical therapy is appropriate. She has a high grade score and is a high risk acute coronary syndrome. So I would agree with you. I would use physiology to try and better understand if I need to treat both. I would also use imaging because one of the messages I like to give in these high bleeding risk patients, if I want to make sure I can stop the DAPT at 1 month, is to get as good a result as I can. And that doesn't mean only angiographically. And then the question would be for me, what am I going to do for DAPT? Am I going to put her on warfarin plus DAPT or warfarin and Plavix only? I have to admit, more and more, I'm only doing Plavix, warfarin Plavix, especially if I'm not doing very complex stenting. If I'm doing very complex stenting with lots, maybe the bifurcation stenting or left main, I may then consider triple therapy for the first week and then dropping the aspirin afterwards. But more and more, I'm starting to feel comfortable with Plavix and warfarin. Is that what you do too, Eva?
Absolutely right. You are going to take a look at my case. We are going more and more into this strategy. Some kind we are foreseeing the guidelines. So, but in fact, this is imposed by the daily practice, the reasonable daily practice. And like in this case, very high bleeding risk subjects, this is, I think, a very decent and very reasonable strategy, having in mind the fantastic result from the Onyx 1 trial, the comparison that you have shown very well, the comparison between complex and non-complex was really amazing for me. We are one of the biggest recruiters into the trial, and it was a huge pleasure for me to see these complex patients and complex lesions treated on the proper way with a good stent. How good is the result? Of course, in some cases, like you mentioned, we need optical OCT or IVUS optimization in order to achieve good result, but no doubt the stent also is very important. So even in such complex cases, we can allow ourselves to be on the safe side, to use oral anticoagulation with single, in most of the cases, clopidogrel antiplatelet. This is also my strategy, absolutely.
Well, let's let Flavio tell us what he did.
Okay.
We can learn from that.
So if I can summarize for our colleagues your opinion, you both agree that the procedure should be as simple as possible, and this is a good advice always. The second is that radial approach should be a must in an acute coronary syndrome in general, but in particular in this lady with high bleeding risk, that you would address, if possible, the target lesion first, and perhaps as an only intervention. It's not clear whether you want to treat one or two lesions. And then there are two important questions you raised. Ivo suggested to use of physiology to decide whether to treat or not an non-culprit lesion. And Azeem wants to see the IVUS or the OCT to have a more precise idea of the vessel size and the final result, which is certainly a very good advice. And the most difficult part is how to manage the dual antiplatelet or single antiplatelet therapy in combination with oral anticoagulation. So let's see what I did, because I did personally this case several years ago. It's an off-hour case. Can we see the procedure, please? The next slide. So I also decided that the LAD was not only the most important, but very likely the culprit lesion because of this ST segment depression in the anterior lead, which might be secondary to hypertrophy in a hypertensive lady, but might be also a sign of ischemia. As you see, it's a simple procedure, balloon preparation with a 3-0, predilatation. It's an Onyx stent. I didn't put it the commercial brand, but it's the only cetarolimus eluting stent. It's 3.5/18, so I think it's well sized for this lady, and it's the shortest iodine implant because, you know, the longer the stent, the higher the possibilities of having thrombotic complications. So I stayed really mean in the length. The next, please. The next slide will show the result. And there you have, it's one incidence with the wire still inside and one without. Remember that the patient has advanced chronic kidney disease, so it's just to limit the quantity of contrast, there is good flow, and so the procedure was done. But considering that I had a good radial access, that I have given something like 25 cc's of contrast media, and the procedure took less than 10 minutes, I did the following. Next, please. I engaged the right coronary artery, used the same balloon to predilate the right, a similar stent 3.5/18 Onyx in the right lesion, and an inflation to high pressure. This goes at about 4 millimeters diameter. Next, and as you can see, it's a decent right with a good territory. It's a dominant vessel. And my idea was, well, I have not given too much contrast, and I wouldn't like to see this patient on the table again because of angina or whatever on the right coronary artery. So this added other 5 or 7 minutes to the procedure, other 20 cc's of contrast. And we can argue whether that was the best thing to do. But at that moment, I decided to do it that way, to offer her, who is relatively young, 65 years old, a complete revascularization, just because all was going smoothly and the lesions were simple, as I said. Next. This is the ACG after the procedure. You see there is not much change, so it's confirmed that the ST may be secondary to the LV hypertrophy. The total amount of contrast was 80. I treated the patient only with some unfractioned heparin. And as you see, the echocardiogram after the procedure showed a moderate impairment of the LV function. FA is ejection fraction. In Italian, it's 36% immediately after the procedure. What do you think about what I have done? And now that you know the result, we have more information to decide on the most important part of this case, that is the management of the antithrombotic therapy.
I tend to do a similar thing to you in that I try to avoid bringing patients back multiple times, especially patients with mechanical valves, because every time you stop their warfarin, even if you bridge them, you take a risk, right? So I like that idea as a message, you know, this is someone where if you had to stage anything, you're going to have to stop a warfarin again, and you take a risk every time you do that. So I think that's great. That's what I would have done as well. Like I said, I've become, you know, I'm a high user of intracoronary imaging. In sort of 80% of my cases, I use it. I'm not sure I would have done any better job than you did. I would have probably, the result looks angiographically fantastic. You know, the one question maybe I have is just to address the question from the audience, which was, what would you do if you didn't have the Onyx stent in your cath lab? And maybe if you, Flavio or Ivo, could address what you would do in those cases.
Well, if I might start, that was at the very beginning of the availability of the Onyx. So all the evidence we have today was not there. So I did it just with a wishful thinking that the initial data that were related also to the Resolute platform were confirmed. Today we have the evidence, so we can go with more certainty. At that time, we didn't have not even the Leader Freedom study. So what I did was using my most beloved and the one who at that time had the better evidence in favor, and it worked. But now things are easier because we do have scientific evidence.
Very similar. In fact, we are quite big users of zotorolimus eluting stents nowadays. But we have on the shelf probably as continuation of the Onyx trial, we have on the shelf also Biofreedom. Probably it's one of the decent alternatives. I also saw the question from the chat, and this is probably one of the best alternatives of Onyx. But definitely, in case we have complex cases and cases with big tortuosity, definitely we are using more and more the Onyx. Even in some cases, we are using the Onyx as a bailout. So in case other case doesn't go, in most of the cases, the Onyx is going. I would suggest Flavio to continue because the time is going.
Yes. We go to the end of the story. If we can see the slides, well, this is the recommendation. I mean, it was she was supposed to remain in 1 month at least of triple therapy with oral anticoagulant and 2 dual antiplatelet therapy. Next one, and so this is what we did. We followed this European recommendation, and now you can see that with a lower heart rate, it is clear that the ischemia was anterior, so that likely the LAT was the culprit lesion, which was also the tightest lesion. See that there is a rapid increment in the ejection fraction. Now is before discharge, it went up to 43%, and she was discharged on Coumadin as she was. This was never stopped, and this is the recommendation: clopidogrel and aspirin low dose. Next. She had an uneventful hospital stay. This is the therapy. She went home with the indication to continue aspirin only for 1 month, clopidogrel for 6 months, and then continue oral anticoagulation alone, as recommended by the last European document, which of course was written in 2017, before the data we have today. Next and last, the program was not maintained because after 5 months, she came back to the emergency room complaining fatigue and asthenia. And this was because without our evidence bleeding, she had an hemoglobin which was 6.3. So she was deep anemic. She was losing blood from somewhere apart from the hemolysis secondary to the mechanical valve. And so, of course, we interrupted the dual antiplatelet therapy. She underwent blood transfusion. And the last slide tell you the end of the story. She comes regularly to have blood transfusion. So she has this chronic anemia with the kidney failure that is progressing because of her rheumatoid arthritis and all the problems I told you in the beginning. So she's progressing to an end disease, kidney disease, and she needs a regular transfusion. But she never bleed openly, and she never had either restenosis or thrombosis, and her ejection fraction keep on being normal. That's the end of the story.
Fantastic case. Congratulations. A part of congratulating you, you showed very well that this particular lady patient was a really high bleeding risk patient. So, and more than obvious, the practice is changing with the guidelines, but also the opposite is true. The guidelines are changing with the practice. So it's probably in this situation, the discontinuation of the antiplatelets would be reasonable even earlier, probably in the future.
Yeah.
Mm-hmm. It's a great case, Flavio. I think for the sake of time, we're going to move on to Ivo's case. And then the couple of questions from the chat, maybe we can address right at the end, which I think would be relevant for both cases.
Okay, guys, thank you very much. It's my huge pleasure. I'm Ivo Petrov, coming from Bulgaria. And I will show you also a case with a high bleeding risk patient that was quite difficult to be managed because mainly of his comorbidities. Yes. So I'm going straight to the case report. It's a 78-year-old male patient with high-class stable angina and dizziness. And he had also a high-grade aortic stenosis with AVA 0.7 and 57 of average mean gradient. In his medical history, he because of paroxysmal atrial fibrillation and stroke history. He is on anticoagulation, but also he has chronic kidney disease, G3B. So he is definitely a high bleeding risk, but also high embolic stroke risk patient, and because of that, he is on anticoagulation. The therapy at admission, as you can see, is typical anticoagulation, beta blocker, amiodarone because of the atrial fibrillation episode, and also rosuvastatin and torozimib. Into the echocardiography, nothing special, a part of the critical aortic stenosis with good ejection fraction and sinus rhythm with left ventricle hypertrophy signs and diffuse ST depression. I mentioned he had high-class stable angina. At the lab results, he had mild anemia and unfortunately low GFR. During the hospitalization and the examination, we found something additional and very important for the clinical decision. So this is the solitary nodular formation into the right lung that give our life even more complex. This is the coronary angio showing this, I mentioned already, high-class stable angina patient, distal left main stenosis, and I would say critical stenosis of the right coronary artery, as you can observe. And also you can observe the calcification on the aortic valve. What about the decision making? The Euroscore in this particular patient is high. It's 6.25%. And unfortunately, his suspicion with carcinoma pulmonum, right lung carcinoma. And what would be in this high Hasbled score and high surgical risk patient? It would be interesting for me to listen to your opinion.
So Flavio, why don't you make a comment and then we'll move on.
Well, certainly I wouldn't consider surgery in a patient that has the suspicions of lung cancer. So the first thing is to rule out this diagnosis, because this will impact the long-term survival and the treatment strategy. And then, of course, considering he has no cancer, the question will be whether treating the coronaries before and then the aortic valve, or the aortic valve before and then the coronaries. But first of all, I want to know if he has or he has not the lung cancer.
Yes, it's a very, very good point. In fact, in our situation, we did the biopsy of the lung, but we didn't have still the result, the histological result, and the patient, in fact, was deteriorating. And because, of course, like Flavio mentioned, we in this particular patient wouldn't go for surgery because of the very high risk. He's almost octogenarian and a lot of comorbidities. Definitely, he's candidate for TAVI and endovascular intervention of the coronaries. And if you allow me, I would go further to show what we have done, if you don't mind. As I mentioned, we were discussing within our team and even our colleagues from surgery. They were absolutely reluctant to think even about operations, so they gave us the possibility to make the endovascular work. Also, the syntax 2 score was telling us that the patient is more indicated for PCI than for surgery. So we did a very simple one stent into the critical right coronary artery, and also stenting of the left main toward the LED kissing balloon, and stenting of the proximal circumflex artery. After resolving this, because of the critical stenosis of the aortic valve, we decided, waiting for the result, histological result from the biopsy, we decided, as you see, we implanted 4 onyx stents, and as a bridging to the decision what to do with the aortic valve, and for TAVI probably, we decided to make a balloon valvuloplasty that we did using a 22 millimeter balloon, relatively undersized. It's about 80% of the mean diameter. And onto the control echo, we see relatively good result with reduction of the peak and the mean gradient. So in this case, I would ask the audience and you, what about the discussion about antithrombotics, and after that, what would be the strategy toward the carcinoma and the aortic stenosis treatment? What would be your opinion?
Yeah, I think even the audience are asking the same question. I see on the chat. When you have a patient on anticoagulation, should you give triple therapy? For how long? Flavio, you gave, for a month triple therapy. There's some data that shows a week may be enough. But we also have Onyx 1, where we allow patients to take a single antiplatelet agent with anticoagulation. So Flavio, has your practice changed from that case you showed us was from 3 years ago? Has your practice changed?
Well, certainly we would be less aggressive now with the antithrombotic therapy. I would feel much more confident on reducing the treatment in a very high-risk patient to single antiplatelet therapy, plus the oral anticoagulation. In this case, as I said, it's very important to know what is in the lung of this patient, and I would reconsider which is the indication for the oral anticoagulation, to reassess this indication.
I will answer with my presentation continuing. As you mentioned, the precise DAP, Flavio mentioned this relatively simple score compared to the inclusion criteria in Onyx trial. It's really very simple. So following the precise DAP score, we are seeing that this patient is a very high bleeding risk patient. And in this situation, definitely we need a tailored approach. Azeem mentioned already that in some patients, even into the guidelines, this guideline is from 2019, it's allowed to maintain double antiplatelet therapy as short as only for 1 week. But this is one option, so to have triple therapy for 1 week and after that to discontinue the aspirin. But also it's possible in some recommendations and algorithms, it's possible even to remove the second. In most of the cases, to remove the aspirin since the beginning and to leave the patient only on anticoagulation and clopidogrel. And in fact, Azeem also mentioned already that in the Onyx 1 trial, the participants, we were allowed by protocol, note 4, to use single antiplatelet therapy since the index day. So we have used all these indications and reason, and we stayed with this patient on apixaban, low dose, and clopidogrel. And the rest of therapy is more than clear. You mentioned already that the Onyx 1 clear study was very important in order to show not only the high bleeding risk, but also to show in one of the sub-analyses to show the results into the atrial fibrillation. And this is the sub-study with this trial comparing atrial fibrillation patients to non-atrial fibrillation patients. And it was very interesting to see that the firm endpoints of mortality and myocardial infarction, there was practically no difference in this very robust endpoint. As a conclusion of my case, I would say that among the high bleeding risk patients undergoing PCI with Onyx drug-eluting stent, treated with 1 month double antiplatelet. Over 1/3 of the patients had history of atrial fibrillation. So it's an additional complicating factor for these patients. Of course, what is the exact strategy in these patients that are with atrial fibrillation? Further studies we need. And the presented patient is illustrating the successful endovascular treatment and favorable early follow-up of complex patients with extremely high bleeding risk with the application of the updated strategy of direct oral anticoagulant and only single antiplatelet treatment. Thank you very much for your attention. I'm listening to you.
Great. Ivo, thank you for that fantastic case, which again, I guess highlights, maybe not all of us, all our participants treat to TAVI and PCI, but they all face patients with atrial fibrillation who need to undergo PCI. And so it's good to have more and more reassuring data on these patients. I want to we're running really almost out of time. I want to address maybe some of the questions we've had from the audience. So I'm going to maybe address it to each of you. So Flavio, there's a question about, your case. Patient comes in with an acute coronary syndrome or STEMI. They have a mechanical valve. They're on warfarin already, right? And you take them to the cath lab. Okay, so you haven't had time to stop the warfarin. And maybe you get back the INR and it's 2.5. What do you do as far as periprocedural anticoagulation? Do you give them heparin? Do you give them low molecular weight? Do you give them bivalirudin? What's your approach?
Okay, my approach is even in a patient with a good level of oral anticoagulation. I mean, this is a mechanical valve. I mean, it's not mitral, it's aortic. It's a little bit less worse, but it's still a mechanical valve. You need to have at least 2.5, 3.5 INR. And that was the case of the lady. So first of all, if you cannot go radial, I am not sure you should go for a coronary angiogram. Probably you ask help to someone who is more expert, but making a bad puncture in the femoral might be even more dangerous than the medical management, first. Second, you always need to give some unfractioned heparin. Despite the oral anticoagulation, you need a short shot of sodium heparin, maybe 300 to 500 units, 5,000 units, because you have catheters, and catheters may coagulate inside. We know that. And then it's about doing a rapid procedure, reducing complexity. If you are going to use a stent, the shortest and largest. Using high pressure, as you said, using imaging if you are not certain about the good result, and then is the management of the dual or triple therapy afterwards.
All right, great. Thank you so much. And then, there is a comment here about the RCA stenosis, and I think both Ivo and I mentioned that, probably both of us would do IFR, FFR. I think most of us are using more and more of it. So we agree with you. It is useful when you're not sure about the diagnosis. And last question from Umberto, Ivo. I think we all agree, and it's an important message from this about stent optimization when you're going to stop DAPT earlier. One of the ways you can do that is use imaging to make sure the stents are implanted, but we have to realize that we have colleagues around the world who work in very challenging environments where maybe imaging is not as easily available, it's expensive and so on. What advice do you have for them on how to make sure they get an optimal result?
Great comment. Thank you very much for this question. It's a question from our world. So, in Southeast Europe, the availability of the technology is good, but the applicability is not so good because of lack of reimbursement in many cases. And unfortunately, both IVUS and FFR and OCT are not reimbursed at all, zero. So we are reserving these tools for complex patients in which we have some suspicions and something to decide more to optimize. And because of that, we are using the Jean Fajadeh strategy. We are doing the procedures IVUS-like. So we are trying to use the lessons from the IVUS for the patients in which we cannot do IVUS or it's too expensive to do IVUS. So we are we are using proximal optimization. We have also in mind a big step down between the left main and the LAD and the circ. We are following also the stent boost and all the other tools that we can use in order to achieve a really good result, because like Umberto mentioned, we have to have really a perfect result, having in mind that probably such patient will stay only on single antiplatelet and the anticoagulation. So we are using all that is possible to be used for every single patient. So-called tailored approach.
Right. Thank you, Ivo. Thank Flavio as well. Time flies when you're having fun, especially when you spend time with friends where you can learn a lot. And we've really come to the end of our time in this webinar. I wanted to thank you both for two very good cases and very thoughtful cases, where I hope for the audience today we highlighted the importance of this group of patients, high bleeding risk patients, and how we showed in the two cases there's no one single answer often for our patients. We still have to be doctors. We have to tailor our therapy, whether it's intervention, it's how many stents we put, which vessels we treat, or the antiplatelet therapy to that specific patient, trying to get the best possible result. We also shared with you some of the Onyx 1 data and some of the sub-studies, because we do now have a very good drug-eluting stent where if you need to shorten DAPT, you can do so safely. So thank you both again, and thank you for the attendees for watching. This has been a great session and very educational. Thank you.
Thank you. Thank you, Flavio. Thank you, Azeem. It was my pleasure.
God bless.
Bye-bye.